Hello, everyone. Hi, Beth, Heidi. I don't know why you invite me, but but I think I can do this. Um, so this is a perfect example of a case that required a ventricular support device during PCI. So this is a case of a 87-year-old female that presented to the ER here at Mount Sinai with chest pain and STEMI, troponin of 7.4 with an EF of 19% on echo. All the risk factors here and great medical therapy that included the dual antiplatelet and Loprester and Crestor and insulin. We take it to the Cath lab, and what we find is a 3-vessel CAD with left main disease, instant restenosis of the distal left main, proximal LAD and proximal circ with severe systolic LV dysfunction. This is a picture of the right femoral artery, and as you can see, this is a bad stick. This is a profound stick. I just left it for just to mess with the fellows. We went and we had the wrist stick. This is how we do. We get access here in the Cath lab. We do it on the fluoroscopy, and we use also micro access. And that's the advantage of doing this, because if it's a bad stick, we can re-stick. Okay. What happened here? Okay. So this is a picture, and as you can see, it's a complex bifurcation lesion with left main involvement, 95% distal left main, 99% ostial circ, and 99% ostial LAD. As you can see. There's also a lesion here on the circ, LPL. And this is the picture of the LV, which shows the bad LV dysfunction with a EF of 15%. As you can see the contrast here, just going around here in circles, and that's a bad sign whenever you see this. This is a selected picture of the RCA with a early bifurcation here, and so what we decide is to go ahead and put a ventricular assist device, as Cameron said before. There's many devices here in the Cath lab that we can use, and the question is which one. The balloon pump studies have shown that there's not much benefit. I think the SHOCK 2 trial showed that there's no benefit. They're still used in the Cath lab, post-MI for the most part. Well, let me just go back here. Okay, wait a minute. Okay, let me go back here. Then there is the tandem heart, which is, again, a large bore access, 17 French system with also, you need to go transeptal to the left atrium. That can be challenging and time consuming. So there's a role for every of these devices in the Cath lab. We used, when they first came out in the late 2000s, we used many tandem hearts, but we still here is collecting dust in a corner in the Cath lab, but we still have it. They're still available. There's also cardio help, which is also a heart-lung machine that it's a little more complex, requires of the perfusionist to come and set up the device. So that can be also time-consuming, and we did a couple of cases last year, and we planning to do some more in the future. So we go ahead, we decide to go with Impella, which is the easiest, I believe, and also because of the size of the sheath, we have two available pumps in the cath lab. They're 2.5 and the CP. From my experience, 80% of our cases are done with the 2.5, which is only 13 French, compared to the CP, which is 14. And in intervention cardiology, as you know, the smaller the better. So you always try to go smaller. Okay, so 80% of our cases are done with the 2.5. Okay, so this particular case was we used a CP. You saw the LB, the muscle hardly moving, and we felt that we needed the support. Okay, so and also the angiogram here shows. Give me 1 second. There you go. It's a good size lumen. A little calcium here, nothing bad, but for a CP, I think it was a good decision to go. Okay, so we go back. So this is you see the Impella here sitting in the ventricle. This is the motor in the aorta, and we do 2 kissing balloons. It was easy to wire. We had a run through in the LAD filter in the circ. Those are the 2 wires of 1-2 wires here that we use in the cath lab. Two high pressure balloons, nicely open. So the intervention went pretty quick and was successful. We did a kissing balloons of the left main of the LAD and circ. We put a DES in the LPL. The Impella was inserted and it was removed after the case without any complications. The take-home message is that these mechanical support devices with patients undergoing high-risk PCI and a setting of acute MI. There are multiple devices, as I told you, tandem heart, balloon pump, cardio help, and they're all available, and they all have a role in providing support. Education, I think, is the key. You have to train the staff, because if they don't know how to use the machine, doctors they're not going to want to use it. Hopefully, the prognosis of these cardiogenic shock patients can be improved with the use of these devices. Thank you.